we'll go ahead and get started since we've got lots of stuff that we want to go through and get through as many questions as we can. But to get us started, my name is Kyle Schuchter, currently an emergency medicine clinical pharmacist at the Ohio State University Wexner Medical Center in Columbus, Ohio. I'm really excited to have so many of you on to chat about something that is very common for many of us. So, culture follow-up in the emergency department. I'm really excited to have you all here and really looking forward to some excellent discussion. I'm looking forward myself to kind of hearing about other cool things that other institutions are doing related to culture follow-up. And we've got four wonderful panelists that are here joining us today to really answer any questions that you all have related to culture follow-up. So without further ado, we will go ahead and get started. Just to give you all an overview of kind of how this session will work and kind of the structure for things, we've got four panelists this afternoon. I'll provide each of them with some time to kind of introduce themselves, as well as kind of go through just kind of an overview of the services related to culture follow-up that they provide there. After that, we will kind of transition to the Q&A portion of the session. Thank you all for submitting so many questions ahead of the webinar. So we've got a list of all the questions that you all submitted, and we will roll through all of those questions as we go throughout the webinar. We've also got a couple poll questions just to kind of get a feel for the group and different services and initiatives that other individuals are helping out with at other institutions. But to get us started, Liz, if you want to go ahead and kick us off, Liz is our first panelist. So Liz, take it away.
Awesome. Thank you so much for moderating this, Kyle. My name is Liz Rodzicki. I am an emergency medicine pharmacist at Ohio State with Kyle. I have been at Ohio State for almost 10 years now and have been very involved in the culture follow-up process. Our current record that we use is EPIC, and we primarily service an adult population, and we follow up on many different results. So STIs, urine cultures, blood cultures, skin cultures, respiratory stool, HIV, hepatitis, and then we get a number of miscellaneous things that I think there's a question. I'll go into a little more detail on that later. Currently, we do offer this service 7 days a week. So we do have AEMP pharmacy services 7 days a week. We are not fully 24/7, but we do cover late into the evening hours. So typically these are reviewed twice a day. So we have one person assigned typically in the morning and then one person doing it in the mid to late afternoon. So most results are followed up within 12 hours of them coming back. It's kind of our bare minimum standard. Additionally, outside of just our ED, we do also have 4 advanced urgent care locations that our EM providers all rotate through. So we cover the cultures for those. We currently do not review negative results. I think this will probably come up later. We used to review in our in-basket or receive all of them, both negative and positive, and it tended to be a lot of information to sift through. So we have turned that off. So we are not reviewing negative results, and thus we can't really de-escalate. In terms of our process for how our pharmacists do it, we are credentialed and privileged through the medical center, and we have a specific privilege for our pharmacists to do that they have to apply for. We do not currently bill for services, but we're getting really close, and I think I'll talk about that later. There's another question that we're exploring a lot of things, and it's been quite a few years in the process of getting us close to where we are now. And we don't currently offer expedited partner therapy. It's something that the question comes up frequently, and we have on occasion done it, but it's not something we have a great infrastructure set up for with our current system. These are some examples of our EHR. So like I said, we use Epic and we have a shared in-basket. So any result that is categorized as either microbiology or immunology orderables within Epic that comes back after a patient is discharged and the result is positive comes to a shared in-basket. So all of our pharmacists that do the culture follow-up have access to this in-basket, as well as a couple of our residents. The results also get directly routed to the attending provider that ordered them. So they see those simultaneously, but we also receive them in our in-basket. And as you can see kind of over here on the right side of the screen, it does note when they're different in-baskets. So we have a different one set up for the urgent care clinics, for our emergency department, and we have some other a community hospital where our pharmacists do it as well. So you don't have to be signed into all of the different pools, depending on which results you're supposed to be reviewing, but ultimately they end up in a single in-basket, which is this micro results in-basket over on the left side. And then when you're looking at the in-basket, this is kind of an example of how they show up. So you'd be able to see what the result is. You can click onto the result and get some more information. From this screen, you can also generally see which location they were at. So you understand there's a few nuances and how we document differently for our ambulatory encounters and urgent care versus our ED encounters. You can also quickly review what medications the patient was prescribed, past medical history, if they have my chart allergies, that kind of stuff, all from one click screen while you're starting to review the result. And then here's some examples of our standard documentation. This is something that we have evolved a lot over the years in. When I first started, we really just had a standard note for change, no change, and maybe like a patient contact note. But we've really worked on this over the years to help our documentation move more quickly. And especially for some of the things that we were having to add in a lot of detail. So our asymptomatic bacteriuria note is pretty evolved in that it allows you to walk through and document appropriately. This patient does not meet any of these criteria, and it's all spelled out in the note. And it makes the documentation of these go quite a bit more smoothly. So it's something that I think it really helps our pharmacists be more efficient in how they document. And then this is an example of just one of our standard, this would be our urine change note. So patient came in with a urine culture, it would mention the pathogen, they presented with symptoms of either pyelonephritis or cystitis. We would have some standard phrases if they were empirically treated, and then we would have our plan that follows after that. We also, for the order type, could have it be whether it's done as a privileged activity or if it was discussed with an attending provider. And then the follow-up action kind of has our three possible scenarios of I contacted the patient, discussed the plan, sent a new prescription. I attempted to contact the patient and had to leave a voicemail, or I was unable to contact the patient and leave a message. So it really does help to improve our workflow as we're documenting a number of these throughout the day. This is just another example of our STI. So this could be for a number of ours, but most commonly we're looking at gonorrhea and chlamydia results as well as our vaginitis panels. So it does also build in, like for chlamydia, which are the appropriate therapy options. So doxycycline is listed, azithromycin is an option, and it kind of just gives some prompts to help remind us too of what the correct medications are for certain disease states. And then finally, this is another thing that's developed over the years. We have some patient-friendly communication that we send out. So we do have letters that we send to the patient, either through the EHR or on a physical letter if they don't have my chart set up, that can provide some additional education after we've talked to the patient, or for STIs that were empirically treated if we just need to notify them. And within these, we include links to CDC guidelines, that type of thing, which again makes it really helpful and efficient for our patients.
Awesome. Thank you so much, Liz. I will turn it over to our second panelist, Dr. Cassie Doino.
Hi, everyone. So I'm Cassie Doino. I'm currently an assistant clinical professor at the UConn School of Pharmacy, but my clinical site is within the UConn Health Center at the ER there. So that's where I'm able to participate in our discharge culture reviews. It's a newer process that pharmacists have integrated in at our institution, so probably a little over a year now. So we're definitely still kind of in the process of updating stuff, but definitely able to clinically participate. So a little background on our emergency department. We're a 42-bed ER. We see about 35,000 annual ER visits, mostly adult populations, but any PD we do see will be through the ER. So there are some opportunities to follow up on cultures, well, rare, but still sometimes see. In terms of our culture review, like I said, still a little bit newer, but so it is multidisciplinary at this time. We don't have full 24/7 pharmacy coverage. So it is currently right now a process conducted by both advanced level practitioners as well as pharmacists. However, collaborative practice is currently in progress. So we're hoping to be able to integrate fully there. In terms of when we review them, currently it's generally once a day, and then as needed, it's kind of checking in whenever cultures come through. Generally, our results we will see between 9 and 10 a.m. during the day shift. So that's when we'll initially start. And then our workflow is driven by our EHR, which is also Epic, and our in-basket messaging system, similar to what Liz had gone through as well. We do review negative results and can de-escalate. So I'll talk about that a little bit more with the screenshots. So we developed actually an EHR workflow utilizing background clinical decision support logic within our EHR Epic, where based on culture results, susceptibilities, and antibiotics prescribed, basically a result and summary of each patient flows to our in baskets and three of the following scenarios. So sorry, it's a little, can't see it super great, but I'll try to explain it as best as I can. So the three scenarios would be a positive culture has resulted and there was no antibiotic prescribed, a positive culture resulted and whatever antibiotic prescribed is potentially resistant. And then the third is that negative culture where an antibiotic was prescribed, so it does provide opportunity for de-escalation of therapy. However, it is the pharmacist's role to then look at that in-basket message and do a full clinical review, because we know the results might not always have more specifics that we need to dive into. So we review, determine appropriate next steps with regards to those results, and then we discuss with our advanced level practitioners. And then we are able to do any follow-up documentation, prescribing, and contacting patients. So like I said, it's a little small, but this just shows the overall patient summary report, where it's identifying what culture to review, kind of the clinical scenario to review, as well as it does have susceptibility reports for those that are positive. And then just wanted to show, this is the same summary, but for example, with a negative culture result, but you can see that you also are able to identify the antibiotic the patient was placed on, as well as ED course is actually where our providers are doing some real-time documentation. Okay, you can go to the two more. Thanks, Kyle. Perfect. And then this is also where, from a pharmacist standpoint, we are also documenting within the ED course. So we're able to attach whatever culture results to our documentation, and then we're able to e-prescribe anything. So if you want to go to the next slide, this is where after our discussion with the providers, we're able to e-scribe on behalf of them. And we actually do have some smart sets that were developed within our EHR. This is an example of a UTI one, just because we see those most commonly and are following up on urine cultures most commonly, and they have kind of our default guideline-based recommendations. So it's a kind of quick click to be able to send to their pharmacy. So that is kind of a little bit of background on ours.
So thank you so much, Cassie. I will turn it over to our next panelist, Dr. Kelly Wang.
Hi there. So my name is Kelly. I'm an EM clinical specialist at Sarasota Memorial Hospital. I've been here since 2016. We have been doing culture review for over 15 years, I believe. So it's been quite a long time. We cover a lot of cultures. Essentially, we try to capture any positive culture that is from a patient who was seen either in our emergency department, either of our 2 freestanding EDs or our 7 urgent care centers. So we cover all of those patients, and essentially we have a patient list that's set up for that. So if you go to the next slide. So this is our patient list. So if you can see on the left side, we have all the positive cultures come up when they're new. The ECC culture review line is blank. And so we fill those in, and that's kind of how we triage things and sign it off for the next pharmacist. So how it works for us is we have different ER shifts. And so the first pharmacist who comes in the morning at 7 is primarily responsible for culture review, as well as any patient care that comes in. So they'll start reviewing the list at 7 a.m. We start calling patients around 9 a.m. And then we continue to essentially review the list throughout the day. So there's not really any like one specific touch point or one specific pharmacist who's assigned. It's however many pharmacists come in throughout the day. We're all looking at the culture list throughout the day. And we, again, continue to call patients through 9 p.m. And then overnight, if there's any emergent cultures that come back, like a blood culture, for example, we could call the patient overnight, may touch base with a physician to see if they want us to do that, or if it could wait till the morning. If you could go to the next slide. So this is a picture of our culture note. We have recently, in the past couple of years, restructured it, so it's a little bit easier for our pharmacists to kind of click through. This is the first page of the note. So we have our microbiology, which will auto-populate in the note. We have any other lab results that may not be tagged as microbiology in our lab. So sometimes PCRs will come in the lab section, etc. We have pregnancy results that auto-populate, as well as our prescription history. So this will show what prescriptions were sent for the patient in our electronic prescription writer. We can also add prescriptions through the button there right from the note as well. So if you go to the next slide. This is an example of one of our urine culture notes. So as you can see, it's kind of small, but it's a lot of just clicking. So we used to have a lot of free text and quick codes, and we try to move away from that and to streamline the process and optimize our efficiency in documentation. So we have a current therapy section, the interpretation of the results. Are they sensitive, intermediate, resistant? What our plan options are. If we contacted the patient, did we reach them? Did we have to leave a voicemail? Were they symptomatic? Are they pregnant? And then did we send a prescription to the pharmacy? Is there any follow-up recommended? Are we deferring or faxing any results to another facility or primary care provider, et cetera? And then if we had to talk to a attending physician, then we will document that here as well. And all of these sections have a little comment box so we can free text additional information pertinent to that section if we need to. And then on the right side is how that populates in the note in the chart. So the left side is, how we see it. And then once we click save, that's how it looks in the chart. So this is just one example, but we cover blood cultures. We don't do COVID, but if a patient calls, we'll provide them the result. We do GI culture, stool culture, C. diff. We do all STIs, urine cultures, vaginal screening, candidiasis, BV, trichomonas, and then wound cultures as well. We also have some protocols for things like HIV. We don't intervene on those ourselves, but we do at least get notified of the result on our list, and then we can escalate it to a provider, and we have a process that outlines all of that information. So everything here, we do have protocols for in place that our pharmacists reference with standard treatment regimens and any education that's needed for the patient. And we do have physician care plans so that we can or prescriber care plans that we automatically are able to send in prescriptions without speaking to a provider unless the protocol outlines specific instances in which we need to consult with a physician. And we can electronically send the prescriptions on behalf of the prescriber per these collaborative agreements with them. And we don't bill for services, and we do not offer expedited partner therapy. For de-escalation, we don't review any negative cultures. The only time we really see negative cultures is if they have a positive culture that shows up on our list, and then we just happen to see the rest of the cultures as well. But otherwise, only positive cultures will populate on our list, or technically any abnormal culture is how our lab documents it. We did recently implement a change in our protocols to de-escalate dual gram-positive coverage for wounds only. So if a patient is on strep coverage and staph coverage and they only grew strep, then we will call them and de-escalate to DC whatever the duplicate coverage was for those patients.
Perfect. Thank you so much, Kelly. I will turn it over to our fourth and final panelist, Dr. Joshua Sen.
So my name is Josh. I am an emergency medicine clinical pharmacy specialist at U of L Health here in Louisville. I did PDRL1 at a community health system here in Louisville, and then had the chance to go start EM service at another community health system. At that time, the Baptist Health System in Kentucky. There was a part-time LPN doing cultures once a week, looking at all these results once a week. So that was an opportunity for us to take over. And eventually we switched to Epic. So I got to work with that. But for the last 5 years, I did that for 5 years. And then for the most recent 5 years, I've been at U of L Health, and we operate on Cerner. So when I got here, we routinely participated in cultures. We've kind of expanded that, the depth and breadth, covering more cultures within Cerner and across, our health system is like 7 hospitals, 4 of which admit patients. And so the other 3 are kind of freestanding ED, but we provide remote coverage for those culture results as well. Each ED has its own collaborative practice agreement. So any prescriptions that we send on behalf of patients are done through each of those medical directors, and they've all signed off on that. You can see we review all sorts of cultures, basically anything that populates as a result that results, whether it be positive or negative after the patient has been discharged, kind of populates in our queue. So that's an opportunity for us to capture some of those opportunities for de-escalation of antibiotics within our system. Yeah, so collaborative practice agreement. We hit a couple roadblocks in terms of looking at billing for some of these services. Our previous clinical coordinator ran a report between all the EM pharmacists. We looked at like over 800 cultures between all the EDs and standing EDs, which is, a lot of time devoted to that. So we talked to the billing department, and we couldn't bill for a visit that was related to a previous already billed visit in the previous 7 days. So we ran into some roadblocks that. And so we just, operate under the fact that, we know we can't bill for these services, but we can, chart the time it takes in some of our other metric charting to kind of capture the work that we are doing. And we know from a stewardship perspective and EM pharmacy expansion of services perspective, it was something that we've been doing and we want to continue to do despite an inability to bill for it. We do de-escalate antibiotics, and then currently not doing expedited partner therapy. Some of the medical directors took issue, but weren't super excited about calling in scripts for patients they had not seen directly in the ED. So that's some ongoing discussion with that. Kyle, if you want to go to the next, I've included this is an example of, our culture queue or discharge culture queue. It's available right off the tracking board. And those drop down boxes, you can see I can help cover peripherally if another ED doesn't have coverage, but we get positive and negatives in here, and you can click on that and go into the chart as well. All right, next. Yeah, that's just a picture of our Cerner work queue, and the results callback queue is easy access from there. And then last slide. Yeah, so again, I select which facilities, and all these results are standard across whatever ED you're looking at. So, if we're filling in at different EDs or covering remotely, it's the same report. And then the last slide is just an example of some of the documentation that we do. Unfortunately, specifically with this feature within Cerner, the dot phrases aren't necessarily available for this particular charting. A lot of us have Microsoft Word documents, so we just incorporate stuff in. So whatever note that if we are done with this particular culture, no further action required, we hit, we're done, we're closing this out. Whatever note that we've put in here populates automatically into the chart. So the documentation is available there. Additionally, if we have to send a letter to a patient, that is handled by the Department of Emergency Medicine administrative staff via certified mail for results that need to be followed up. Generally, we have, at least at our main hospital, we have EM pharmacy coverage 22 out of 24 hours of the day. So for the most part, in addition to our other EDs, these are checked once a day. And then any critical values, specifically positive HIV results or positive blood cultures, microlab calls the EM pharmacist directly for those. So we get away with, only really having to check this once a day. The rest of the ER kind of blows up throughout the day. So we kind of handle this in the morning, first couple hours. And then when it's honestly, unless it's a critical value we're called on, we don't really look at it again until the next day.
Perfect. Thank you so much, Josh. And thank you to all four of our panelists for taking some time out of your afternoons to chat a little bit more about ED pharmacist culture follow-up. Before we actually transition into the Q&A portion of our webinar, I did want to go ahead and just launch a quick poll question, because I do know that there are many institutions out there that might not potentially be following up on cultures yet. So they're really kind of not sure where to start, or they want to start services, but they haven't yet. So you can go ahead and launch the first poll question that we've got, just to kind of get a feel for how many of you are actually currently offering culture follow-up services in the ED at your institution. Looks like our results are trickling in. It looks like the overwhelming majority of you all do currently offer culture follow-up services in the ED at your institution, but we do still have a couple sites that aren't. So I think that will be really helpful for those individuals, just to kind of get some ideas and kind of first steps for really where to begin to start culture follow-up services. So I'm going to go ahead and end that poll. So you guys should be able to see about 81% currently do offer culture follow-up services, and about 20% currently do not offer those services in the emergency department. So that will kind of take us to the first question that I've got. And Liz, I will turn it over to you for this question. But again, for those institutions who may not have yet developed culture follow-up services, do you kind of have any recommendations for kind of what some of those first steps would be for folks that are really looking to initiate some of those culture follow-up services?
Yeah, I think it's a big task. And I think the first step is understanding the scope of what you're being asked to do and making sure that you have the right capabilities to do that. So a few things, pharmacy staff training. One thing that I think is very unique about this process where pharmacists are following up with patients, talking about the medications. Oftentimes, we are also talking about a potential diagnosis with a patient. So it could be that you're talking about their new STI diagnosis, right? So they now have chlamydia, and you need to also talk about the medications they're being treated with and what the plan is for that, which I think pharmacists are very comfortable with. But you also have to think about other things like prevention of this infection passing on to other people, making sure there's some of that STI counseling. What does the follow-up look like for those patients? I also think often for urine culture specifically, we're getting a culture 2 or 3 days after the patient's been seen. And if the antibiotics they were empirically on were not covering, your pharmacist needs to be comfortable talking about the progression to pyelonephritis, deciding if it's still safe to treat the patient in the outpatient setting. And so a lot of those things I think EM pharmacists get very comfortable with, and I think it's why we're well positioned to do this, but you do really need to make sure that you have the right staff who are trained to do that and comfortable. And a lot of it is working with EM providers to understand how do they consider things for disposition and deciding when it's appropriate to treat in the outpatient setting versus having the patient come back to the hospital for certain things. So along with that, I think staff training is important, but a protocol development is really important to tease out all of those things and anticipate those potential needs. So deciding if you're doing a collaborative practice agreement versus credentialing based on your institution practice for other types of things, thinking about what your physician oversight is. So we always have an ED attending on site that if we're not comfortable with a case or we need to run it by someone, that we can talk to them about, especially when it comes to clarifying diagnoses. So making sure that if it's your physicians asking you to do this follow-up, that they also understand what their role will be and that they will always be willing to help you with those things. I think you also really want to make sure you have quality assurance processes in place to make sure that you're tracking what your pharmacists are doing, having some accountability to make sure that when they are managing these things independently, that they're being held accountable for best practices. I think you also want to plan through some other process things. So how many times you're going to attempt to contact a patient? Is it just one time and you've made one attempt and that's it? Or do you need to have a couple different attempts to contact a patient, and really going through all of those possible scenarios beforehand so that you have consistency among your pharmacists that are doing it? Standard documentation, I think we've all showed how that really helps workflow. So I would certainly advocate for that. And then I would also really advocate for best practice or best understanding of what the scope and resources are. So some of us have talked about only reviewing positive results. Some of us also receive negative results. Are you de-escalating? Thinking through like, what is the feasibility for how often your pharmacist can review the results? When do you have pharmacists there? Are they able to do it on the weekends? What happens if a pharmacist isn't reviewing it over the weekend? Should it be someone else like APP who's doing it, who's maybe there on the weekend? So really trying to anticipate all of those things ahead of time, I think is really helpful.
Awesome. Thank you, Liz. I think those are some great pointers, and especially for those who have maybe not started culture follow-up services and really aren't sure where to begin, because as Liz alluded to, there are a lot of different things to consider. And culture follow-up is pretty complex, but I think those are some great pointers for folks who are looking to start those services in their ED. That kind of segues nicely into the next question that we had submitted, and I'll turn it over to all four of you. I think one of the things that's really nice is that we do going to end that poll real quick. I think the other thing that I think is really important that everybody alluded to in their intro is how do we actually integrate culture follow-up services into our EHR? So obviously each of our panelists, I know Liz and Cassie both use Epic, Kelly is on Allscripts, and then Joshua is on Cerner. For each of you guys, could you maybe just talk a little bit about how you all have kind of integrated the culture follow-up services within each of your respective EHRs? And Liz, we'll start with you.
Sure. So as I mentioned, we use the shared in-basket model where the positive results or abnormal results that come back after discharge. So there's certain criteria they have to meet to flow into our in-basket. This was originally set up by our Epic ASAP team, which is our emergency department kind of IT support through Epic. It was a combined pharmacist / provider review. So we used that method instead of just having it be built within our pharmacy system, since we were originally having APPs or physicians do it on the weekends. So I would definitely say to reach out to them if you have Epic. There's a lot of other, I think, ambulatory places that use shared in baskets, so they should be able to help set that up for you. One thing I would definitely advocate for and consider is to think about the positive versus negative results. So when I first started, we actually used to document on all negative results as well. And as we've grown our program, it was really decided that we just don't want to see those results, so that we could expand to doing other clinics and kind of saving our time with some of those. So I think it's really important to understand how it's set up and what your scope is.
Great. So very similar to like Liz said, so we work off of Epic as well through the in-basket messaging, so very similar. But like I had mentioned in my intro, we have a little bit more filtered. We actually, this stemmed from a resident project a couple of years ago, working with, again, our ASAP team, which is our like IT analysts within Epic. We're able to do a lot of background logistical work and work within the Epic workflow to identify and filter out those specific cultures that would then flag our in-basket for specific patient scenarios. Because what was happening before was we were running into whoever was reviewing the culture would identify that the patient was already on appropriate therapy, and that was just some time that wasn't necessarily needed. So we were able to filter that using Epic background logic. So that actually helped reduce time to intervention a lot and was allowed for our providers and pharmacists to focus on the cultures that needed more detailed clinical review. So I definitely think working with your Epic analysts is super helpful. And then also, like Liz alluded to, bringing in different aspects of the review process with the APPs, even nursing is super helpful, just to be able to identify, make sure you're covering all bases within your culture review. You want to make sure you identify any barriers in other realms of interdisciplinary work. And then also too, it's really helpful how we have everything summarized kind of in one in-basket message, and we're able to kind of overview everything that occurred with the patient while they were in the ER, whether it be like 24 to 48 hours prior. All that information is there for you, and then you're able to kind of click into the patient encounter if you do need to do a little bit more digging on information. But generally, most of the information that we need is kind of all within that patient summary. So I find that allows for a really good efficiency of reviews too. And then Liz had also alluded to, but documentation and communication to be standardized and have some sort of template is also super helpful, especially if you have pharmacy learners that are assisting with these reviews, pharmacists, new staff pharmacists that are starting, or people integrating into the workflow. That's always super helpful too.
So for us, we have all scripts and we have a patient list. So the patient list is populated with patients who had a location at either one of our ERs or urgent care centers, and then had a result that we have filtered into our list. Our pharmacy IT team is the one who builds those lists for us and then pushes them out for us. We can also customize them ourselves, but they've kind of helped us with that. So anything that's abnormal will populate on the list if they were seen at one of those places. And then we get that list, it just continuously populates throughout the day. We have that one column on the left, which is where we document, and that's kind of our communication to each other. And we have a certain nomenclature that we use to communicate. So we always put a star because it pushes it to the top of the list. We put the date, and then we'll put like UC penned for urine culture pending, or we'll put LVM ×1, left voicemail ×1. We contact the patient for up to 3 days and then send a certified letter. And we have a few instances in which we don't send a certified letter because they don't really require additional follow-up. It was more like an FYI for the patient. And yeah, that's basically how our list functions.
Similar to, as kind of everyone outlined, I worked with our IT on building that particular list, and they can filter in who has access to that list. I know at some of the EDs prior to ED involvement, there are certain providers that can have access to that. And at my old hospital system, when we first transitioned to Epic, there were several providers had access to that. And so there was a couple of days where they were just clearing the stuff out without even reviewing it. So we had to turn off their access to that. But obviously everyone doesn't have that luxury of, enough pharmacist coverage to really just do it solo. So you do rely on some of those APPEs. We are fortunate in the sense of all of our pharmacists have access to this, regardless if you're an EM pharmacist or not. And that's helpful. Our PGY1 resident, we have 7 PGY1 residents, and EM is a core learning experience for them. So they all come through and they all have access to that. There's rarely a month that we don't have a learner, be it a resident or a student. So we've definitely incorporated them into that workflow. And the documentation is the same for the residents and our regular EM pharmacists.
Thank you all for sharing. I think definitely lots of opportunities to really optimize the EHR and really make culture follow-up as efficient as possible. I think I've learned all kinds of new things and kind of exciting things to build into the EHR to really help make that culture follow-up as efficient as possible. So I think you all shared some really great opportunities and some great ideas, especially for those who are kind of looking at how to kind of better integrate their EHR with all their culture follow-up services. Before we transition to the next question that was submitted, I do want to go ahead and launch our second poll question. So for those of you who do currently provide culture follow-up services at your institution, do you currently have a collaborative practice agreement in place? So I know we talked a little bit about collaborative practice agreements kind of in the beginning, and each of our panelists kind of shared whether or not they do have that collaborative practice agreement or credentialing and privileging. So really just wanted to kind of get a feel for how many of you all have kind of one of those collaborative practice agreements or credentialing and privileging in place at your institution. I'm gonna go ahead and end our poll and share the results with you all. So it looks like we're pretty split on this. So it looks like just over the majority of you all do have a collaborative practice agreement in place, and pharmacists are able to independently review some of those cultures and results and follow up on those independently. But it does look like there is also just under the majority that do not currently have a collaborative practice agreement in place, and results are staffed with a provider. So that segues nicely kind of into our next question. So for those of you that do currently have have this credentialing and privileging or a collaborative practice agreement in place. Would you be able just to share with the group kind of how you started that process and kind of what it took to kind of get that up and running? And Liz, we'll start with you and go down the line, and Kelly next, and then Josh next.
Yeah, so we do it through privileging through the medical center. So typically what we do for our new pharmacists who are in our EM group is we would have them practice for about 6 months to a year of doing these and staffing with and attending to make sure that they're really comfortable with things like disposition discussions with patients and thinking through some of those things. It also really provides a lot of good opportunity for them to have good in-depth discussions with the attendings. And we typically try for about 6 months to a year to make sure that they've seen all the potential different types of cultures or results, especially for some of the more rare things. So we've developed kind of a checklist that they could use that once they've achieved these, that they could apply for the privilege. And then there's a test that they have to take. This is pretty standard for all of our medical center privileges for pharmacists. And then once they pass the test, they're granted the privilege through the med center. We do not have our residents currently pursue privileging, mostly because it takes about a year for our new pharmacists to do it. And we don't feel like it's necessarily feasible for our residents to complete it in that time. And again, it gives them a lot of that good face time with attendings to have those in-depth discussions.
For us, a lot of this was kind of already in place when I started, but we have expanded a lot since I've been on our team. So we have a lot of, like, all of our prescriber care plans are documented with like clear guidance documents. So you could pull up, blood cultures, and it tells you exactly what to do for each type of culture, or like when you need to contact a physician versus when you need to call the patient and just tell them to return automatically. You don't need to speak with a physician. Same thing for like urine cultures. Everything is very clearly documented and outlined. So all of our EM pharmacists do get training on all of these. It's part of our like training checklist. We also have an intro to culture review service PowerPoint that we go through with our pharmacists. We do have our residents do this as well. So our PGY1s rotate through culture review service on their staffing weekends, and they do that for the first half of the year. So they're really just paired with an EM pharmacist and primarily do it, under preceptor guidance, and we review all of their notes and everything just to give them experience. And then our PGY2 residents do practice with the culture review service as well. And all of these prescriber care plans are signed off by our medical directors of each site. We also review any changes or new protocols with our emergency medicine P&T subgroup committee. So we'll take those to the committee, outline the changes, we'll have discussion and update as needed. And then we try to review all of the protocols every couple years just to see if there's been any changes that are needed to make to each one.
Yeah, we have a P&T approved collaborative practice agreement that's reviewed every 2 years and signed off by all the medical directors. Our PGY1s and obviously students who come through and kind of help us with this under preceptor guidance, and our PGY2s after several months of training and going through kind of our orientation competency checklist are able to do this as well. But like I said, we do this without having talked to a physician. A lot of the students that we have, I have them practice, even though we don't have to ask their permission, I have them practice getting acceptance for that recommendation to some of the providers so that they have, a win for the day on an intervention. But also we have a lot of medical residents that come through. And although I don't need their permission to change it, I think there is benefit in talking to them about that. We frequently run into UA diagnosed UTIs, and, we're having to change that therapy. Now it's on me to, something's resistant, but there were no symptoms. Do we really need to treat this? But having a discussion can help them in their future considerations for both their charting and just general management of some of these patients.
Thank you all for sharing. And that is kind of a nice segue into the next question. I think all of us who do routinely follow up on cultures can definitely attest to the fact that does not come without its challenges. So for each of our panelists, would you all maybe be able to share kind of the biggest challenge for each of you that has come up related to culture follow-up?
So Josh stole my thunder on this one, but I think unclear documentation from an ED visit, or maybe not an appropriate diagnosis that was given, and then having to backtrack and have that conversation with the patient is definitely a significant challenge for us. I think the other one I would say is critical results process. So we are not 24/7. We're moving closer towards it. And I think the more and more we have taken over of cultures, the less and less comfort our nurses and physicians feel with it. So still making sure that they understand the importance of those critical results, especially for blood cultures, to make sure that something happens overnight and it's not deferred to the pharmacist the next day.
Yeah, I would say one of our biggest barriers, in addition to what's already been listed, is just the contacting communication of results to patients. A lot of times you call 3 times, you don't hear back, or they got discharged to a skilled nursing facility and it's, you send the fax and cross your fingers sometimes. So really just maintaining and making sure that we have consistent communication within the results in basket, just to make sure that in documentation, so providers know if it is time when the pharmacist has left for the day, if the patient's calling back, there's clear notes on what they need to let the patient know. So just making sure consistency of communication occurs. And I would also echo the just appropriateness of actually prescribing antibiotics. We just often see inconsistency of prescribing practices within our providers. So I think having that face-to-face discussion can be super helpful to kind of just question why maybe they were started on the antibiotic, if they're comfortable taking it off. A lot of times too, whoever started the antibiotic might not be there that day, so it's passing off the results to another APP. So a lot of different things, but I think it's also a really great opportunity for our learners as well. So that's been a piece of feedback I've gotten from students on my rotation, is getting to experience that type of communication. It's good practice for them. So trying to make light out of some of the barriers, but those are definitely some ones that we experience a lot.
Some of the barriers that we have been in communication with our leadership about recently have been some of the urgent cares. We don't have as close of relationship with our urgent care centers as we do with our ERs, because the urgent cares are staffed primarily with family care physicians, but they're all part of the same group as the ER physicians. So they still report to the same medical directors. But so they don't know us as well because we're not at the urgent cares, but all the ER physicians know us. So it's a lot harder to communicate with them. And sometimes they'll follow up on their own cultures outside of us following up. So sometimes we kind of do double work. Like we'll have triage the culture when 9 o'clock comes around. We call the patient only to realize, oh, urgent care called them an hour ago and they recommended this. It's not really what's part of our protocol. We probably would have done something different. So them kind of following up on their own results independently has caused some duplication and conflicting work. So that's been kind of one of our biggest issues that we've seen. And then the other thing is sometimes they'll also prescribe provisional antibiotics. So usually what our practice is, we'll review the patient's prescriptions to see if appropriate therapy was sent. And then if it was, then we'll sign off our culture as, it's appropriate therapy based on what the bacteria or culture result was. We won't go and read the note in detail, but as some of us were going to read the notes in detail, we discovered that they sent the prescription, but instructed the patient not to take it unless the result was positive and we received a call, or they received a call. So that's kind of been difficult for us. So we are in communication with our urgent care centers to try to establish better communication and understanding of what our practice is and how we follow up on results, so that they're aware. Because I think if they're more aware of what our practice is, then they would be more comfortable not necessarily following up on the BVs themselves, or not sending in provisional prescriptions, because they know that we will follow up on those positive results. So we're working on it.
Yeah, most of what everyone else kind of already said. One of the issues that we've encountered is our outpatient documentation for all of our physician groups is Epic, and we still have Cerner on the inpatient side. So, a lot of these patients are seen within the U of L health system, both outpatient and inpatient, but that documentation doesn't always transition over. And so when we reviewed this a year or two ago in P&T, there was a provider who had a big problem with not, knowing something happened to their patient on the outpatient side. And so they were calling for us to, in addition to all the other duties that we have to do, like submit more documentation to their office about, we reviewed this culture and we changed this therapy, and it was too much. So we ended up, getting all the medical directors on board to saying, no, if you really want to see this, you can log into Cerner yourself and see it if your patient tells you that, they just got recently treated. So it's kind of a workflow issue with the two different systems, but that's the finance game and what was cheaper to do where. So
Thank you all for sharing. Yeah, I think a lot of those challenges are challenges that really all of us face across the board with culture follow-up. So lots of consistent themes there. We do still have quite a few questions. We're going to jump around just a little bit since we are short on time. I want to make sure to hit the questions that multiple people submitted. So we can go ahead and launch our third poll question. So I think one of the things that comes up a lot, especially in the emergency department, is there a way that we're able to kind of help justify additional FTEs? So I think across the board, we're always looking for more FTEs. So for those of you who do currently provide culture follow-up services at your institution, have you been able to actually justify additional FTEs as a result of just the culture follow-up services that you guys offer there? I'm gonna go ahead and end the poll, and I'll share the results with you all, but looks like about 29% of you actually have been able to justify additional FTEs as a result of culture follow-up services, which is great. But it does look like the majority actually have not been able to do this. Liz, I know that at our institution, we've actually been able to do this. Could you share a little bit with the group about how we've actually been able to use our culture follow-up services to help actually justify additional FTEs?
Yeah, absolutely. So this mostly had to do with the expansion. So the urgent care sites were opening and they're run by the EM department. So it's the same providers and APPs that rotate through the ED also go to these advanced urgent care locations. And so when they came to us and asked if we would be willing to do the cultures, it started with a numbers game of, are we able to manage these? At first, they opened just one, and it was kind of a minimal amount of cultures that we would additionally be doing a day. But then as they further expanded, there's now 4 open and there's a 5th opening. We kind of held the line and said, like, we cannot take additional workload on for these. However, if you're able to provide us with an FTE, we would kind of take that FTE and absorb it as an ED pharmacist, but then fully cover all of these urgent care locations. So we, instead of just having one person designated, like one FTE just for doing all the culture follow-ups, we felt like it was better to fold it into our ED workflow so we could all kind of rotate through that service. So really what it came down to was a numbers game of considering how many results we would be reviewing, how many we're intervening on. And I think having that baseline of the physicians really appreciated us doing the follow-up and didn't want to have to do it themselves, so that when they were posed with this whole potential new group of patients where they would have to, that they were willing to pay up for that FTE for us.
Awesome. Thanks, Liz. I think it's nice because culture follow-up, as you all know, it's a lot of work. So absorbing that into our workflow really kind of detracts from other services that we're providing. So it's definitely nice to have that support from our provider colleagues as we kind of help with a lot of this culture follow-up. And the next question that we'll transition to, we had a lot of questions related to billing for culture follow-up services. So we'll go ahead and launch our 4th poll question. So for those of you who do currently provide culture follow services at your institution, do you currently bill for services? So I will go ahead and end the poll. 100% no. So it looks like most institutions and most individuals on this call are not billing for culture follow-up services. So I know, Josh, you at your institution have looked into billing, and Liz, you've also done a lot of work related to kind of getting billing to go live. Could the both of you just kind of share what this has looked like and any tips for other individuals at other sites who are maybe looking to start billing for services?
Yeah, we're exploring this, at various points in time. Your administration is like, how can we generate more FTEs or money and billing for all types of services? Because as most of us do, probably pretty robust outpatient and care services that they're able to bill for that have developed out in the last couple of years. So we started exploring that and met with our Department of Emergency Medicine assistant director and reached out to some people in finance. And basically, from what I was told, we could, and at least from the AmCare side, from what I was told from some of our pharmacists, is they can bill for MTM type visits and patient counseling and virtual telehealth visits via commercial insurances, but not necessarily CMS or Medicare, Medicaid patient populations yet. And even when that day came, our financial people sent us some documentation of standards of billing, one of which was a limitation being able to bill for a visit, counseling, whatever it was, if it was related to a previous visit that had already been billed within the previous 7 days. So we ran into some roadblocks there and not sure if that capability from a billing standpoint will be possible for us. We will continue to explore that, but as of right now, it's just an extension of our current EM pharmacy service line services.
Yeah, and I would say we've really run into a lot of those similar barriers, Josh, that it's not done anywhere. So there's not a lot of precedent set for this, and it doesn't quite follow exactly how any other ambulatory service that's billing is done. So we've worked very closely with our ambulatory colleagues who are very progressive, and they've been so helpful in understanding things like incident to billing and what's the difference with compliance and how do you have those discussions with compliance about, your decision making and how it's different because of a result that's come back. So they've been super helpful. So if anyone's interested in doing that, I would definitely encourage you to work with your ambulatory counterparts because they know those details of billing so much better than we do. I think one of our big recent challenges has been telemedicine and its ability to be billed for by Medicare. So up until just a couple of days ago, it was set to expire on the 31st of March. So we were like almost ready to go with trialing this in our urgent cares. And then it was going to expire in December for Medicare billing for telemedicine. And there's no way we're having patients come back in to the hospital to do these in-person visits. So we paused it and we're really waiting to try and get a longer than 3-month extension. So now that it's been extended through September, we're going to kind of revamp things. And I hope that it's something that we're going to be successful with. And I promise I will share that once we are able, hopefully, to do it. But it is not an easy process. I've been working on this for almost 3 years now, and we haven't gotten it to the finish line yet.
Thank you both for sharing. Yeah, I think billing is one of those things that would be nice, but there are just so many roadblocks and logistical considerations. So, Liz, you'll definitely have to share with our EM group if we're able to go live with it in some of those steps. I know we are at time. I do want to address one last question that many of you submitted ahead of time, and that relates to expedited partner therapy. So we'll go ahead and launch our fifth and final poll question for the webinar. So does your current institution offer expedited partner therapy or EPT? We'll go ahead and end the poll and share our results. So the majority, all 100% of those who answered in the poll do not currently offer expedited partner therapy. I think as we alluded to before, I think Josh, you kind of alluded to this, there are some logistical barriers and kind of considerations with expedited partner therapy, which I think is largely why a lot of institutions have not kind of had large uptake in expedited partner therapy. I do know that there are other institutions that are offering expedited partner therapy. So definitely, if you know those individuals or institutions, feel free to share with the group. But there are a lot of logistical issues and concerns with EPT, but it is a great service. Just logistically, how do we operationalize that is, I think, the biggest roadblock that we've all run into. I don't want to hold you guys over. I know we are at 4:02. You guys had some wonderful questions that you submitted ahead of time. I believe we answered most of the ones that are in the chat. I will go ahead and put my email up. So if there was a question that you had that we didn't get a chance to answer, feel free to send me a quick email. I'm happy to connect you with all 4 of our panelists and kind of provide you with responses to your questions. I've also included a QR code here on this slide. If you've got any feedback for our webinar today, feel free to use that QR code and submit that. And then lastly, if you do have any feedback or suggestions for future webinars that you'd like to see our AMP Career Development Committee put on, use that same QR code and feel free to submit those as well. But I know we are a couple minutes over now, so I will give you guys some time back. But thank you all so much for joining us. I think we had some great turnout and some great discussion on culture follow-up. But feel free to reach out if you all have any additional follow-up questions.
Hey, Kyle, one more thing.
Yeah.
Oh, I was going to say for the expedited partner therapy, like currently we don't actively practice it, but one of the things that we started about 2 years ago was we have doxycycline discharge kits that we give away, 7-day supply of doxy from our EDs that we actually get supplied from the health department. And so it's been a good relationship so far, and hopefully that well won't drive up in terms of that supply, but that's something that has been in discussion about reapproaching the health department to ask if they would be in favor of us asking for more, because if that's an option, the people that we, as we discharge them, we give them 7 days of doxy from the health department. If they have a partner that could benefit from this, can we give that to them as well? Because currently the agreement is that we're just giving it to patients directly in the ED and not necessarily in that capacity. But those are some conversations that we can have that would kind of be a little bit of a roundabout in lieu of prescriber prescribing something for someone they hadn't seen. So
yeah, thanks for sharing, Josh. I think that's a great example. I think each state's Department of Health, they offer so many things, and I think things that like many of us might not even be familiar with. So really, how do we leverage some of those resources that are provided to kind of help with our culture follow-up, I think is a great example. But again, I know we're a couple minutes over. Thank you all so much for joining today. I'll leave this QR code up if you guys want to provide any feedback or send any suggestions for future webinars. But again, thank you all so much for taking time out of your afternoon to join, and hopefully you walk away with something cool and unique to kind of bring back to your respective institutions' culture follow-up services.